Thank you for your kind introduction, sir. Good morning, everyone. I was sure that my topics would be almost covered by Dr. Chandrasekhar sir and Dr. Matthew sir. So I came up with something slightly unconventional presentation. Like, I'm sure you are aware of this game, Mafia. The rules are simple. There are innocent villagers and there are the mafia members. And the detectives will have to find out who are the innocents, who are the mafia members, so that the village can be saved. So here the mafia members are played by the autoantibodies in our body, and the innocent villagers are the child's immune system. And we clinicians serve as the detectives to determine who are innocents, who are suspicious, and who are definitely burning down the village. A little more about the innocent villagers. Oh. Sorry. How do I go back? Yeah, a little bit more about the innocent villagers. That's the child's immune system. Children are definitely different from adults. They are not just small adults. Their immune system is constantly changing. They're dynamic. They're still learning the rules of the village. And even the onset of certain diseases vary, the severity varies. For example, lupus nephritis, for that matter, is more common in younger children, and it's even more severe in younger children. And even the prevalence of certain diseases vary, and even non-rheumatological differentials are different in children. For example, younger child comes up with aches and pains. You think of growing pains as well. If you see an adolescent boy who is obese and comes with a limp, you think of orthopedic conditions like slipped capital femoral epiphysis or avascular necrosis of hip. So the differentials are wide and different in children. And even you can see the child at a different point of evolution of the disease itself, and there are various confounding factors. And even muddying the water are the infections. So children are prone for more infections, and there can be more false positive autoantibodies in children. Adding to the confusion is the parental anxiety. Parents will come to you with a positive report and they'll ask you to do more tests so that they'll be out of the anxiety. But in that process, we end up ordering more tests, and it comes positive, we'll be nowhere, whether to treat the reports or to treat the child. So let's try to understand our players a little more. Before that, a little bit more about the crime itself. So the crime here that has happened is the failure in the judiciary system that was very nicely explained previously. I'll just do a recap of that. So there is a failure of the tolerance mechanism. So our immune system is designed to protect us from the foreign antibodies. But sometimes they can react to our self-antigens also. If at all they do so, that they have to be trained not to do so by our tolerance mechanism. In the generative lymphoid organs, if at all a T cell recognizes a self-antigen with high affinity, they just undergo apoptosis, they just die, so that they don't go out and produce these autoreactive antibodies. If at all a B cell does so, there is even a change in the receptor itself, so that it does not recognize the self-antigen anymore. And some T cells, the CD4 positive ones, also get converted to these policemen called the T regulatory cells, so that they'll take care of any autoreactivity that occurs in the periphery as well. Even in the peripheral tissue, if at all if a cell reacts to a self-antigen, they just do not react like how they would react to a foreign antigen because of the lack of co-stimulators. If an antigen is foreign or pathogenic, there is usually an engagement of something called as the co-stimulators. They're just absent here with respect to our self-antigen, so they just do not react. If at all these still continue to react, the policemen that are trained in the central lymphoid organs, the regulatory T cells, they'll come out and take care of it. They'll suppress this autoreactivity. But if there is a failure of this mechanism, the failure of tolerance, the cells continue to react to our own antigens and produce certain autoantibodies. And our job is to use these autoantibodies to help us in diagnosing, classifying, prognostication, and to know the disease severity. And certain antibodies also predate certain illness, so we can even predict the disease. But the most important thing is to know the difference between the presence and the significance. Presence of an autoantibody does not always mean a disease. So having the clinical context is what matters. Ordering for a test, depending on the clinical context, and interpreting the antibody report as per the clinical context is very important. There is no one autoimmune rheumatological panel that you can order to rule out all the autoimmunity. That should never be done. So I would like to share with you a story of a 5-year-old boy who has come with leg pain past 2 months. Pain is more in the night. It's even waking the child from sleep. And in the morning, he's absolutely normal. He's playful. He goes to the school. And he's brought to you, and you see the child. On examination, child is absolutely fine. And you order for CBC, ESR, CRP. They all come out normal. I want to ask you, how many of you would order for an ANA here? By show of hands, how many of you would order ANA here? Okay, nobody. That's great. Okay. It's a different story here. A teen girl with fatigue past 2 months, generalized aches and pains, and on examination there is some joint tenderness. And you order for incidentally you see that in urine routine there is some protein and some RBCs as well. Would you order an ANA here? Okay, that's great. We'll come back to these stories by the end of the session. So let's try to understand our suspects a little more. So the lens with which we look at the suspects also matter. That is, Dr. Matthews sir previously explained about the pretest probability. A little more about it. We should know 2 things before we order for it. One is a little bit about the statistics, and the other thing is a little bit about the test methodology itself. So statistical is, I will not go deep into it. When you order for an upfront test, it should have a good sensitivity. And when you do a confirmatory test, it should have a good specificity. And to increase the positive predictive value of a test, it should have a good pretest probability. That means to say, you order for a test in a child only when the degree of suspicion is very high. And the chances of increasing positive predictive value is more in that case. If you order just for the sake of ordering, the positive predictive value of the test goes down. So these are the mafia suspects, which we have already been introduced to you. ANA to correct cell antibody, dsDNA, ENA, ANCA, rheumatoid factor, ACPA, and APLA. And how do we interpret these reports? Okay. ANA can be called the sneaky generalist because it pops up everywhere. You see an ANA report every here and there. A parent might come to you with an ANA report with already being tested, or it can be a part of certain panels itself. So ANA is like the village gossip. It's always talking, rarely reliable. It's due to overzealous prescription. It's highly sensitive, but it lacks specificity. Especially in children, there can be false positive ANA reports, and even viral infections can cause transiently ANA positivity. So all this need to be considered before asking for it. So even the techniques have been previously dealt with, but whenever we see an ANA report, a parent comes to you with a report, you see that ANA is positive, always look at, for any test for that matter, you look at by which methodology it is tested. So we prefer indirect immunofluorescence, which remains the gold standard. And ELISA, even though it is less cumbersome and can be automated and even cheaper, it has the chances of having false negativity because it tests for limited number of antigens. So in the report, apart from the methodology, you also look at the titer and even what is the pattern of the ANA. The titer, something very interesting here in children is that 3 out of 10 normal children can have ANA positive in low titers, that is 1:40. So as the titer increases, the false positivity chances also comes down. So always look at the titer in which it is tested. And also the technical aspects also matter, like the substrate that is used. It's the hep tooth cultured substrate that is used. And it also has a disadvantage of not having good expression of certain antigens like Rho antigen, and the reagent that is used, the fluorochrome ratio, and the fixation microscope, the light. Most importantly, the experience of the person who is reading the ANA report also matters. That also needs to be kept in mind. Yeah. So this is finally where ANA behaves responsibly in juvenile arthritis. We do not order ANA to diagnose juvenile arthritis. Instead, we order to know the risk of uveitis. So in this particular set of young children, especially girls, with oligoarticular type of joint involvement, that is less than 4 or less number of joint involvement, if at all they turn to be ANA positive, the chances of risk for uveitis increases. So the uveitis that occurs here is it's a chronic anterior uveitis. When I say chronic, there might not be any symptoms, or the child might fail to report those symptoms. So it becomes our responsibility to screen the child even when the child is asymptomatic to look for uveitis. So if at all a child has ANA positivity and has juvenile arthritis, make sure to send to an ophthalmologist even in the absence of eye symptoms. And if at all ANA comes positive, the frequency with which we test for uveitis also increases. Visions are at stake, so screening for uveitis becomes non-negotiable. So our next suspect is anti-dsDNA. It's like the godfather. It's rarely present, it's highly suspicious and always dangerous. And it's very specific for lupus SLE and more specifically lupus nephritis. And the titer also correlates with the disease activity itself. And the dsDNA lights up in indirect immunofluorescence as a nuclear homogeneous pattern as previously described. Also there is uptake in the mitotic figure. So this nuclear homogeneous uptake can be seen with dsDNA, ssDNA, and even histone antibodies. But to detect specific dsDNA antibodies, we do have different specific tests like the FAR assay, that is the radioimmunoassay. But that comes with the disadvantage of having radioactivity. And sometimes when we have the high degree of suspicion of lupus and we are not sure, we can even do the indirect immunofluorescence in Cryptidia lucile method, wherein the substrate here used is a parasite which has only dsDNA. So if that comes positive, we are more sure of high avid and specific dsDNA antibody. So moving on to our next suspect, it is the anti-Smith antibody. It's like the silent assassin. It never shows up, but if it does, the case is closed. It's SLE. So it lights up in indirect immunofluorescence as nuclear speckled pattern. Although it is rare, it is more definitive of lupus. It does not correlate with disease activity and might be associated even with less severe form of lupus nephritis. And some things more special about this anti-Smith antibody is that it acts like a double agent with anti-RNP antibody. So when you order for an ANA profile, that is the line blot assay, you see so many lines, anti-Smith being positive, Smith RNP being positive, and so on. So you see that you are thinking in terms of lupus in a child and you order for an ANA profile, you see SM is positive and SMRNP is also positive, and now you're confused. Why is SMRNP positive? Is it an MCTD? So we need to remember a little bit about the basics, that the Smith antigen is a part of the molecular complex wherein even RNP is also present. So Smith antibodies against Smith can also appear as SMRNP positivity in the ANA blot. So if both SM and SMRNP are present, it's most likely lupus in a background of the same clinical context. But if only RNP is positive without Smith being positive, mostly you are dealing with MCTD. So our next couple of suspects are SSA and SSB, the Rho and La antibodies. They are like the weather manipulators. They bring in drought in the village. They cause Sjogren, they cause dryness of the eyes, dryness of the mouth, and lupus, and even neonatal lupus erythematosus. So we have this antibodies against Rho60 that is more specific for all these conditions. Antibodies against Rho52 can be present in other conditions also, apart from lupus, Sjogren and neonatal lupus. It can be present in systemic sclerosis, and it is more specifically so in myositis. Something about neonatal lupus erythematosus is something we'll have to keep in mind. Even asymptomatic pregnant women or pregnant women with lupus or Sjogren can have these Rho antibodies against Rho60, Rho52 or La antibodies, and they can get transferred to the fetus around 16 to 18 weeks of gestation. And they can act against the fetal cardiocytes and cause congenital heart blocks and endocardial fibroelastosis, dilated cardiomyopathy, AV nodal disease, sinus node dysfunction, and so on. So it becomes very crucial to screen these pregnant women, though especially those at high risk with previous IUDs or previous congenital heart blocks, with these Rho antibodies, and preferably with an ELISA or a CIA method to look for this titer of this antibody also becomes very important. So to have an overview of the ANA pattern, so these are not just pretty lights. They are like the signatures of our suspects. So when you see a homogeneous pattern, it could be lupus, it could be because of dsDNA, ssDNA, that could mean lupus. Or if there is a speckled pattern, it could be, it could make us increase the suspicion for lupus, MCTD, Sjogren. If there is centromeric pattern, you think in terms of limited systemic sclerosis or CREST syndrome. If it is nucleolar pattern, you think in terms of progressive systemic sclerosis. So when to order for an ANA? So whenever you are thinking in terms of a connective tissue disorder, or whenever you have a juvenile arthritis child, especially a young child with oligoarticular manifestation, you definitely order for ANA, not to diagnose arthritis, but to know the risk of uveitis. More importantly, when not to order for ANA. So you don't order ANA for just vague aches and pains, fibromyalgia or amplified pain syndromes, or just because one of the relative members of the family have some autoimmunity or some antibody being positive, the parents come to you with some concern. You just do not order ANA just to rule out an autoimmunity. To summarize with respect to ANA, it is the context that matters, and the ANA is always supportive but not definitive. So our next suspect is ANCA. It is the demolition crew. Wherever ANCA goes, the destruction follows. There is structural damage, causes vasculitis. As previously described, ANCA is antibodies against the neutrophilic granules that are present. These important antibodies are the anti-PR3 and anti-MPO. And they form a set of phenotypically distinct vasculitis type called the ANCA-associated vasculitis, the GPA, MPA, and EGPA. So in indirect immunofluorescence, they light up as the cytoplasmic or the perinuclear pattern, and even the ELISA method detects the anti-PR3 and anti-MPO antibodies. So we just now had a discussion of whether to do ELISA or indirect immunofluorescence. We can safely say that when the degree of suspicion of ANCA vasculitis is high, we can order ELISA method. If it comes positive, well and good. If it comes negative, and if the degree of suspicion is still high, we can order indirect immunofluorescence or repeat ELISA or both. So that we do not miss out on, if the degree of suspicion is still high, we can follow this gating screening system. So we don't order ANCA very casually. So we have to take it very seriously because it is present in these red flag signs like, when you see a child who comes to you with rapidly deteriorating renal function, like rapidly increasing creatinine, and you see CAS in the urine, either with or without systemic manifestation like fever, myalgia, scleritis, Or you see the involvement, multi-system involvement, like lungs and kidney being involved. Especially with lungs having pulmonary hemorrhage, or a child in ICU having diffuse alveolar hemorrhage or pulmonary hemorrhage. Or you see a child with saddle nose deformity or stridor, which is because of the subglottic or tracheal stenosis, which is more specifically so in pediatric population. These are the only indications for ANCA. You don't just order ANCA just to see if the child has any vasculitis. So rheumatoid factor acts like the street gang. It gangs up with ACPA, that is the anti-CCP. What is this rheumatoid factor, which is already explained to you? It is the antibody against our own antibody, that is the IgG antibody. And these antibodies may be of various types. The ones we detect are the IgM. And how is it important in the pediatric population? Rheumatoid factor, you see a child with arthritis, and you don't order rheumatoid factor just to confirm the diagnosis of arthritis. Instead, you see a child, especially an older child, with multiple small joint involvement, and then you think of polyarticular juvenile arthritis, and then you order for rheumatoid factor. It helps us in classifying them as rheumatoid factor positive juvenile arthritis. And the detection methods have been discussed. So what is preferred is a nephelometry method. The ELISA method also has this advantage of detecting the specific type of antibody that is present, because IgA rheumatoid factor, if it's present, we know that the disease is going to be more aggressive. So rheumatoid factor in juvenile arthritis is not for diagnosis, it is for classifying them so that we can be more aggressive in our treatment as well. It predicts erosion, radiological progression as well. But rheumatoid factor can be seen in other connective tissue disorders like Sjogren's, lupus, vasculitis, and even in infections like tuberculosis, osteomyelitis, leprosy, syphilis, and hepatitis C. So all these needs to be kept in mind and to be repeated after 3 months. So the rheumatoid factor can gang up with ACPA sometimes, the anti-CCP antibody. Again, this is does not help with the diagnosis of arthritis because it is very less common, especially in children. So if you see a child with RF positive juvenile arthritis, you see that anti-CCP is also positive, we just know that the disease is going to be more aggressive and we'll have to increase our treatment accordingly. Our next suspect is the anti-phospholipid antibodies, can be safely called the smugglers. They smuggle chaos into the bloodstream. They cause thrombosis, they cause hematological manifestations like autoimmune hemolytic anemia, thrombocytopenia, skin changes, libido reticularis, and even neurological manifestations like psychosis, seizures. So in children, compared to adults, the primary APLA is more common. The primary APLA is where the presence of APLA is not associated with another connective tissue disorder. So just because the child can evolve later into developing all the CTDs, the primary APLA is more common. And whenever it is associated with the CTD, it's called the secondary APLA. That is more commonly with lupus or lupus-like illness. Again, to add to the confusion is the APLA being positive in certain infections during these concomitant or even preceding infections, APLA antibodies can be positive. So it becomes again important to test for these antibodies after a period of 3 months. So we have this certain set of indications to test for APLA when you see a child with recurrent stroke or any thrombosis, even venous, arterial or vessel thrombosis, or hematological manifestations, or Raynaud syndrome, or digital ulceration, or chorea, or you see that you are suspecting in terms of lupus without much of systemic manifestation, you do a kidney biopsy, you see a thrombotic microangiopathy in the renal biopsy, we have to consider APLA. And also, in any child with lupus, we have to screen for APLA at least once during the diagnosis and screen annually later. So when you do give prescription for APLA, you don't just write APLA, you write all these names of these antibodies, the anti-cardiolipin, IgM, IgG, beta-2 glycoprotein, IgM, IgG, and lupus anticoagulant. Because even these antibodies, the titer with which they are present, the type of antibody that is present also matters, because anti-cardiolipin there can be more false positivities or can be transiently found in other conditions also. If at all, if it is in low titer, can be safely ignored, but if at all it's all triple positive, or the more specific ones like beta-2 glycoprotein or lupus anticoagulant is present, especially in high titers, this needs to be considered more seriously. So again, repeating the test 3 months apart becomes important. Also look at the titer with which the antibody is positive. So our final suspect is the myositis antibody profile. So we can diagnose juvenile dermatomyositis very easily. You see a child with Gauthron's papules, heliotrope rash, and malar rash, and the child has proximal symmetrical muscle weakness. You know you are dealing with juvenile dermatomyositis. Then why should we order for myositis specific or associated antibodies? We still go ahead and test for them to know the phenotype of the juvenile dermatomyositis. This helps in knowing the phenotype of the disease, also to know about the prognosis of the disease itself, and also helps us to anticipate the complications that might arise. For example, the TIF1 gamma, that is the more common type of antibody that is present in juvenile dermatomyositis. If TIF1 gamma is positive, we'll know that there is going to be more severe skin involvement. And if NXP2 is positive, we know that there might be pharyngeal muscle involvement, or there might be even a worse calcinosis, which is very difficult to treat. And if MDF5 is present, even if the child is asymptomatic, we'll still go ahead and screen for interstitial lung disease, because it is a common association along with MDF5. And if MI2 is present, we just take a step back and we are relaxed, because we know that it is going to be a good prognosis. And as described earlier, these myositis-specific antibodies, unlike adults, are not associated with malignancies, especially in children. So coming back to our cases, so all of you were right, we wouldn't order ANA in this particular child because this child just had growing pain. So if ANA comes out positive, it just adds to the confusion to the parents and the treating doctor. Whereas in the second case, half of you were right, we should definitely order for ANA in this teen girl, because the chances of SLE is very high. So to conclude, so you look at the symptoms of the child, you try to do the pattern recognition, and with you look at the pattern like which is pointing towards a particular rheumatological diagnosis, and you do targeted tests accordingly. And then that's how you confirm. And you don't chase any low titer antibodies, do not repeat them unless they have prognostic implications. And even the false positives, lack of specificities need to be communicated to parents beforehand, and in fact we should know about these tests more before requesting for one. So autoantibodies do help in a diagnosis, they guide us, sometimes they mislead us as well. But when interpreted wisely, they help us restore the peace in the village. Having said all that, if autoantibody is positive in a child, it is worthwhile to follow up the child even in the absence of the disease, just to see if there is any evolution of any rheumatological illness. Yeah, that's my presentation. Thank you.